This is a 54-year-old who has a stuffy nose, some anosmia, and headaches. An MR examination was performed. Here are two representative sagittal and a representative axial T2 weighted image. Here are coronal T2 and coronal post-contrast T1 weighted images. And here are some sections that are more superiorly located. So, to the response, let's say, which statement best describes this lesion? Do you think this lesion arose in the superior portion of the maxillary sinus? Do you think it's irregularly marginated and arises in the superior nasal cavity? Do you feel there's no evidence of brain or orbital involvement with the mass? Or do you feel that the mass has smooth, expansile borders? Now we're all asleep. Let's see the responses. Good, another softball, and you all hit that one back at me as well. The mass is irregularly marginated, and it's in that category of superior nasal vault lesions. The most likely diagnosis for this case is 1. Esthesioneuroblastoma, 2. Squamous cell carcinoma, 3. Allergic sinusitis, or 4. An inverting papilloma. Please enter your choice. And the audience response says, a little disparate results here, but I think the majority of you feel, correctly so, that this is esthesioneuroblastoma. Please note on the sagittal T1 weighted image here that there are some profound hypointensity within this mass, which makes us think, because we correlate it with the other sequences, it is always hypointense. Certainly a good indication for calcification. The lesion has invaded the anterior fossa and results in this fairly characteristic cyst at the CNS interface. There are many features that we find in sinonasal malignancy that make us say this is a malignant process. This is something aggressive and nasty. A focal mass always raises some concern of a sinonasal malignant lesion with or without sinus obstruction. Bone changes, both remodeling and irregular destruction or sclerosis, may be the indication of sinonasal malignancy. Remodeling is seen in some lesions fairly typically, such as lymphoma and also, unfortunately, in sinonasal melanoma. So just the fact that there is smooth bone remodeling doesn't make us say this is a benign lesion. Obviously, the presence of invasion makes us say this is a malignant lesion, so invasion of any of the contiguous structures. My caveat at the bottom, beware subtle changes on screening sinus CT. I see a large number of these patients now who have been essentially biopsied during functional endoscopic sinus surgery with fairly obvious findings on the screening sinus CT that was performed. If you see irregular bone destruction, if you see significant bone changes on any of these screening sinus examinations, it's reasonable to caution your ENT colleagues that this may be a mass lesion with contiguous sinus inflammatory disease. This, I think, will reduce the number of, as we refer to them, the peek and shriek kind of ENT examinations where the endoscopist looks up thinking they're going to find benign sinus disease and instead sees a very ugly tumor invading the anterior fossa. Hypercellular tumors of the nasal cavity, and particularly in the superior nasal vault, as this lesion appeared, they are called by the pathologist as the little round blue cell tumors or small round blue cell tumors. They can also present a very difficult differential diagnosis on imaging. And you see the list here that are kind of fall into that category: lymphoma, melanoma, salivary gland tumors, mucoepidermoid or adenoid cystic cancers, esthesioneuroblastomas, sinonasal undifferentiated carcinomas. They can all look very similar just on H&E staining. Only the histopathologist will ultimately know for sure, and very often it takes them a while to make that diagnosis as well. There are some distinctive features, and again, as in this case, the presence of a calcified lesion with that cyst at the CNS interface is very, very characteristic of esthesioneuroblastoma. Sinonasal lymphoma, again, this lesion resulting in smooth bone remodeling, actually pushing the middle turbinates away, although there are destructive changes as well within the nasal septum. The MR examination here demonstrating the lesion essentially carpeting the sinonasal mucosa on the left. Sinonasal melanoma is another disease process I think we can make a reasonable call on if we see a very heterogeneous lesion with areas of T1 shortening, marked heterogeneity within the lesion, resulting in what appear to be fairly smooth bone changes. I think sinonasal melanoma. Sometimes the lesions are very easy to make a diagnosis, and here's a really nice case of a sinonasal melanoma that is almost uniformly hyperintense on this non-contrast T1. I think that's a call that you can make very confidently. So why this case is a esthesioneuroblastoma? We find it to be a superior nasal vault lesion. It does extend into the anterior fossa. There is both bone destruction and some aggressive features of the lesion. We think this is something bad. We do see tumoral calcifications, and those can help you, and the cysts at the CNS tumor interface are very characteristic. Let's move to case 3. This is a 61